So, urine drug screening. Oh, can you switch the slide?
Yep, there you go.
Sorry, I'm sitting here clicking it. Annie and I have been in the same meetings all morning. This really comes from SAMHSA's State Targeted Response Technical Assistance Grant, or the ORN network. And let's go to the next slide. The ORN network provides local experienced consultants in prevention, treatment, and recovery. This is how a number of us on the faculty find ourselves joining you for this ECHO series. Next slide. To ask questions or submit a request for technical assistance, which you can do directly, this is the URL, cell, and email address for those requests. Next. So to just get started, choosing the right test, we're going to be looking at decisions based on the information we need, the substances that are being targeted for testing, the matrix sample collected, and reliability and usefulness of the results, and also, of course, cost. Screening versus confirmation. And this is just really simple as it would seem. Screening is qualitative. This is really where you're getting a positive or negative result only. They vary based on the cutoffs. Different testing products have different thresholds for what trips a positive. These can be done on site as point of care or sent to a lab. For point of care tests, you typically are getting immediate results, and that's really the strength. You may have a greater frequency of false positives or false negatives with some of the point of care CLIA wave testing. Oops, we lost our slide. There we go. Now for confirmation testing, this is what we consider quantitative, and that's typically in the language of GCMS. Gas chromatography, mass spectrometry. This is done in labs only. The risk of false positives becomes very low. It may take up to a week to get those results, and they tend to be quite expensive. Again, that varies by product. These are areas that I think we have to be very careful with within our MAT practices. It's really, really easy before March 14th for us to rely very, very heavily on urine drug screens as a validation of the work that we're doing with clients. Oftentimes, shifting a significant debt and cost to our clients in that endeavor. An example might be a program that I've interacted with that had a lot of variation in the frequency of urine drug testing, and also the frequency of quantitative versus qualitative testing. And in that particular program with, say, 60 clients, everybody having a required urine drug screen that was reflexed for quantitative GCMS weekly, resulted in about a $17,000 a month urine drug screening cost. Much of that shifted to the patients, who were either self-pay or insured, and those that were not reimbursed, that was certainly debt that was being incurred by the program. As a general rule, we like to see that the cost of lab work does not exceed the total cost of treatment in a monthly, weekly, or annual basis. And it's very easy for that to happen with your drug screening. Figure if you have a 10-panel point of care test, reflex, to be GCMS'd each time it's administered. Sometimes those GCMSs, depending upon the lab you're using, can range anywhere from $35 per panel, so that would be 35 times 10, to up to $100 to $200 per panel times the total number of items being tested. And you can see how quickly that cost is going to add up for clients and for your program. Let's look at the next slide. So instead of reflexing a quantitative, when do you order a confirmation? Well, when there's a discrepancy between self-report and the point of care result, when results may change or alter a plan of care, Highly recommended if the plan is to discharge a patient that you do your due diligence. And when needed to confirm the patient is taking prescribed medications. Let's look at the next slide. I feel like I want to mute suddenly. I have a cat that is making a ton of racket. I hope you guys can't hear that. So for example, in Maine Medical Partners, which is one of the groups that I've worked with over the last few years on their MAT expansion build out, they use this Quick Tox product. Test for abuse plus adulterants, and they're looking at the panel of cocaine, opioids, methamphetamine, THC, amphetamine, benzos, barbiturates, methadone, and oxycodone. The adulterant panel, which is certainly recommended, is going to give you a pulse, for lack of a better word, on creatinine, nitrate, the pH, and any oxidizing agents. When we were doing urine drug screens on site with great frequency, this was very helpful to have. A lot of places use observed testing. A lot of places do not do observed testing. Based on the trauma history of your patient and the culture of your program, you sort of fall on one of two sides of that style of doing urine drug screening. But our clients can be very creative at adulterating urine drug screens. There are a fairly high number of products available on the internet that people can purchase. They have interesting and funny names. Two products that I always mention as it results to adulterating urine drug screens. One is called the Whizzinator, and that's an actual bladder that a person can fill with negative urine that they've obtained somewhere. And it fits into the body in such a way that it's very easy to even in the observed urine drug screen to pass that urine. Because of where the person's wearing it, it also is body temperature. Another product that is not something like an apparatus used to bring in fake urine is a product called Urine Luck. And that's a combination of B12 and all of other products that the person takes in capsule form and drinks 2 gallons of water. And when they then do their urine drug screen, it really shifts the gravity and creatinine in such a way that you get a dilute, not masked. So it's really the 2 gallons of water that are diluting the sample, not the B12. And when we were seeing patients on a regular basis, one of the things that we did on site to sort of mitigate that kind of style of urine tampering is we would just come in and start group, and at the end of group, we would do the urine screens. If you just drank 2 gallons of water and come to an hour group, it's people are dancing in their chairs. So let's look at the next slide. So this is a separate test that was used for buprenorphine only, and this is, again, was a rapid tox point of care test to get simply a positive or negative on buprenorphine. I like this very much. The confirmation of buprenorphine is quite expensive, about $200. And reflexing that on a regular basis is one, very, very expensive, and two, there's still a lot of debate about the actual clinical utility of doing that. If you are going to be monitoring a person's buprenorphine levels and metabolite levels on a regular basis and trending the rates of metabolism, there may be some utility there. Otherwise, the simple positive negative is really a strong indicator of adherence, as well as their participation and what you're seeing in the other 9 panels on your tox screen. Let's look at the next slide. So actually, can we go back one? So the other thing I want to say about this, because it can be somewhat controversial, and what I find is that providers are really, really fused with their sort of style of testing. They either want to reflex GCMS on the buprenorphine level every time, or it's just not something that they have included in their index. One of the things that I do and that I encourage you all to do as well is from time to time I look at end user chat rooms. And there are a number of them on the internet, and this is where individuals who are MAT patients with buprenorphine are speaking freely with one another about positive and negative responses to care and what they do with their buprenorphine. And I've learned a lot from just watching these conversations. Some of them are quite terrifying in terms of what people are doing, and some of them are really, really positive and heartwarming. Opiophile is one of the sites that I've looked at for these chats, and that you guys don't have anything to do, but it is something that I would recommend. And the reason I'm going down this pathway with you is because one of the things that I saw was a very robust chat between a number of patients who were all at risk of being kicked out of their buprenorphine program as a result of their buprenorphine metabolite levels. They were engaged in outpatient programs where that was reflexed on a weekly basis, and the variation in their metabolism rates was used as a contingency. And so clients were being asked to come in at a set time each day and do daily dosing under observation. And again, another urine screen, another GCMS on their buprenorphine levels. And many of these clients were under a great deal of duress and stress. They were turning their lives inside out, having to deal with childcare and employment and housing, and figuring out how to go to the clinic every day for what was essentially a $235 urine screen. And it just was very sad reading the responses and the reactions and the distress that these clients were in, of constantly feeling like they were going to be kicked out and feeling out of control with, I take my buprenorphine at the same time every day in front of a staff person, and those buprenorphine levels really look like they're all over the map and they're going to kick me out. And I just don't think that's the position we want to have our patients in. Let's look at the next slide. So here you just get sort of, for those tests that I have identified that Maine Medical Partners use, what the different cutoffs are, right? In terms of the point of care, the Nordex screen when sent out for GCMS, as well as the way that that breaks down as it comes across. I don't know that we need to get into this level of detail for our purposes today, beyond recognizing that each of these tests have thresholds for what trips a positive or negative result. Next slide. And the same here, going on with methamphetamine, methadone, opiates such as morphine, oxycodone products, THC, and buprenorphine. So a little bit of a discussion about THC as it relates to these tests. One of the places I worked when I was at Midcoast Hospital, our medical director, Leah Bauer, did some due diligence and really mapped out creatinine gravity levels across a pretty large sample of urine screens, particularly looking at our patients' THC levels. And what we found was a significant variation and swing from month to month in those particular areas, and their bearing on the person's quantitative or, sort of nanogram per milliliter when they had a confirmation test. And we found variation of around 50 to 75 nanograms per milliliter. And so there had been a practice, a very vigilant practice with cannabis use of really a zero tolerance. And we would see patients that would begin at, say, 400 level, working their way all the way down to, say, a single-digit number, a 7, and still having treatment monitoring responses as if they were continuing to use THC. And what we found with that sort of 50 to 75 nanogram per milliliter error range is when we started to see people getting below 100, we were really treating that as a negative period. And so people are going to make their own decisions about that. And in fact, views in that program around cannabis use has shifted greatly over the last couple of years, as it has in our society. But I wanted to make a special mention of that as it relates to our work. Next slide. So benzometabolism is an area that can be complex, picking up some substances but not others, moving through to identifying metabolites as well. This is a bit out of my depth, and so I'm not going to try to go through the detail on how this necessarily works or functions, but wanted to make this information available to you in your work to review in more detail on your own. And let's look at the next slide. So also metabolism and how this is going to necessarily work. Here you've got known metabolites and you've got patterns observed in patients receiving chronic opiate therapy. And in part, really, this is to help us understand to that level of depth, if you're interested, why on our various tests you will see more than one panel for opioids. You'll typically see, as you've seen here, a panel that's going to pick up morphine and heroin and other natural derivatives, and then a separate test for synthetic like oxycodone. And increasingly, what we need to be seeing is the fentanyl test. They are coming to market on the point of care products. They're tending to be pretty expensive. There still are a fairly high number of in-house labs at hospitals that do not have fentanyl as a part of the standard battery. One of the things that we've discovered with our work in expanding buprenorphine in emergency departments is that there's a fair number of emergency departments that haven't had fentanyl added to their standard urine drug screen multi-panel. So it continues to be an evolving science and an evolving set of operations that we're trying to keep up with. Let's look at this next slide. You'll often get a urine drug screen report, either from the company that you use when sending out for GCMS. I almost want to be able to, can you make that bigger, Annie? Is there a way to magnify that?
Oops, sorry, I'm trying. You see it bigger?
Yep, that's perfect. So this is just a nice, simple example and a way to evidence this. This can be in an EMR, or folks can have paper versions of this in the program that I work with at York Hospital. They are, in fact, not on an electronic medical record, so we have similar paper forms as this that we use that then go into charts. And they're going to vary greatly. Some of these are going to come electronically. Some of them are going to come through the fax. Others are going to be things that you're using in a more homegrown fashion, like the programs I identified. And let's look at this last slide. So a few pearls of wisdom. Pay attention to the validity measures. They should be within range. Look for products that do not include oxidizing agents. If not, repeat the test. If cocaine is positive, it's positive. What we've learned over the years is that there are some substances that the assay reports have just been so well done, and there are not other agents that have been found to mask or mimic. Cocaine is one of those, and though we still see, particularly these days, an uptick in positive cocaine use within our MAT caseloads, that tends to be, for folks, something they're doing weekly or bi-monthly versus on an ongoing basis. The other thing with cocaine is it metabolizes out very, very quickly. Typically within 48 hours, a person can test negative. So again, that's one of those things when you're seeing a positive, it really is a positive. And a few brief conversations with patients about that will save you and them some money of sending this out for confirmation. Opiates panel does not include fentanyl. That has, again, been an issue in EDs where people are coming in and they're actually testing negative for all opioids, but exhibiting significant signs of withdrawal. That's sort of the backdoor into a withdrawal syndrome, and the person's been using fentanyl. Also, what we're aware of these days is there's very little heroin available. It is all mostly fentanyl. Opiates does not include oxycodone or methadone. Those are reported separately. Benzo tests can miss low levels of use. If you're concerned, get a confirmation. You can see false positives with methadone as it relates to diphenhydramine, doxylamine, and ranitidine. You test for the parent, not the metabolite. If you suspect diversion, send for a quantitative level. And that takes us through the slides. And again, wanting to mention, certainly happy to respond to any questions that folks might have about this particular content, but I think we've all moved into some pretty big adaptations with our urine drug screen monitoring as a result of social distancing, and I think there'll be a lot of utility to hearing from folks about what you're doing in that regard.
Great, thank you, Eric. So yes, definitely time for questions. Also, just a reminder, for attendance purposes, please type who is on into the chat if you haven't already. But yeah, we'll take questions for Eric now, or if you would like to also share how you are addressing the urine drug screens during this time of social distancing, the floor is open.
This is Andres Abreu,
Yeah.
MDI Hospital, Bar Harbor. So we have a number of patients on Suboxone here. And with the physical distancing, I've just thought that and for a lot of the folks who are pretty stable, have been on steady doses for a long time, have been at the clinic for a number of years, that the risks of asking them to go get a urine drug screen completed outweigh the benefits. So I've just actually not been getting UDSs on any of these folks at the present time. Previously, we've been doing monthly. And I'm just curious what other people are doing and how that sounds, because I'm just kind of flying by the seat of my pants here.
Yeah, it'd be great to hear what others are doing. Also, the what messaging you're giving your patients around it too, because I know it can be a little bit of a tricky situation.
Certainly the feedback I'm hearing from folks around the state, you would expect varies. Folks are moving largely in the direction that Andres just mentioned. You're really looking at your panel of MAT patients and kind of stratifying by acuity and creating some priority pathways, if you will. Your most acute patients, your most recently initiated, and what we've done in our programs anyway is I've had the staff look at the panel and characterize across those three areas. Who is most acute, who is stable but at risk, and who's really moved into maintenance phases of care, and establishing frequencies of contacts based upon those areas. Certainly expanding the size and duration of everybody's prescription was one of the first things that we did, as well as getting phone and video capacity up and running so that we can have increasingly more personal contact with each individual client. One of the things that I've heard, and stop me if I'm taking up too much time, or we have a case that we're going to be presenting today. And I've really spent a lot of time thinking about this, is I know I'm aware of one practice that has been reaching out to clients and letting them know kind of in a blanket fashion, certainly during this time of social distancing, the requirements for you coming to the office have greatly been removed. We're no longer delivering MAC groups, etc. But we are still going to be doing pill counts and random drug screens. So we do want you to be prepared that you may be called to come to the clinic. They've created sort of a way to operationalize that, where clients come to the clinic, they wait in their car, they receive a phone call when the staff know that halls and egresses and waiting areas are free of other individuals, and the person can simply just walk in, leave a sample, and leave. And they're feeling that that's been safe for people. Part of the discussion we had was, based on where we are socially right now, if you have a positive urine drug screen, or a drug screen that's negative for buprenorphine, are you really going to take them off the buprenorphine anyway? And we should have that conversation with ourselves beforehand, because we want to make sure that we're sending clear messages to clients. I sort of feel like when we say to everybody, we could call you at any moment and have you come in and do a urine and a pill count, that we're sort of escalating people's already baseline of anxiety. And if, in fact, we're not going to apply contingencies based upon a positive urine drug screen or a negative buprenorphine drug screen, are we just raising people's anxiety for a moot point? And I don't know the answers to those things, but I'm certainly interested in the discussion and where others are arriving on these issues. Let me turn it back over to Kayla.
Yeah, I was actually going to say, so today's case presentation is a little bit different than we would usually do. We actually, as a planning group, decided that it's probably best to hold off on a formal case presentation today and actually have more time to talk about just different methods people are using to still meet the needs of their patients. And also, meet the needs that you need for your clinical practice during this time of social distancing. So that was really kind of the point of today's sessions, Eric. So you segued us into it very nicely, actually. So we did kind of come up with some guiding questions around the critical issue, and I can share that on screen. But really, again, wanted it to be more of an open dialogue in this session, so we can share kind of what everyone's doing, how workflows have changed, just really be here for each other. So obviously our critical issue for the case today is how do we provide the needed level of treatment and support to our patients on MAT or with OUD, SUD while using the virtual telehealth model. And just a few guiding questions that we had come up with very quickly, but it's obviously there's more to talk about than just this. But really, have you been able to utilize the telehealth model, and how's it been working? Have you had a lot of canceled appointments due to patients having children at home or other reasons? We know at this time there's a lot of people with their children at home with them all day long, and that might not always have been the case for them, so that could be an extra stress on their life too. So just what additional support services are there for that? Have you canceled groups, or are you meeting virtually instead? Have you noticed an impact on mental health status due to the isolation? And how are you helping patients feel less isolated, and what other concerns do you have? So again, it's not that you have to sit here answering a list of these questions. They were just guiding questions that we came up with to open the floor for some discussion today around what folks are doing. So I can turn it over to the spokes first if you want to share. I know we have Bucksport on, we have EHC, and a few others, St. Croix. Is there anyone that would like to share kind of the modifications you've made so far to accommodate this time of social distancing?
I can go. This is Lisa. I'm at the Down East Treatment Center. Yeah. We've kind of fine-tuned what we're doing. I'm still going to the office to do the groups via Zoom. And our administrative person is there with me. And of course, we're more than 6 feet apart, but and our MAT provider is at home. So what we've been doing is we still have groups at the same time that we had them before, and the administrative assistant starts in the morning calling out to all the clients that are scheduled that day and scheduling a phone meeting with Linda, our MAT provider, and we're trying to work around the groups so people can still participate in the group. If people have an email address, they've been easily able to get in via Zoom. We have some people, for whatever reason, they're either technology or they're using this as a time to not participate in group, whatever the reason. But I think we've got it down pretty well. And definitely the MAT part is working just fine. And the part about the urine drug screen, we're still asking folks to come in and screen. We're not, forcing the issue. We use Peaks Outcome, and they have a separate little area in the back of the treatment center. We have 2 really great collectors that are, still on board, and Peaks has come up with a protocol for keeping, everyone's safe back there. And so that seems to be going well also.
Great, thank you for sharing.
You're welcome.
Others that would like to share what you're doing currently? Elaine, can you speak a little bit to how Maine General's kind of, or the Dartmouth Family Residency has taken, what approach you've taken to all of this? I know you've had a lot of different kind of creative workflow ideas and thoughts around this.
Sure, I wasn't sure if we were still doing spokes, so I was just waiting to sort of jump in.
Around.
I don't think any of us have the perfect answer. I mean, I think that's what it comes down to. I think it's balancing what you feel comfortable with versus, and I channel my inner Leah Bauer as often as I can, where, we were chatting one day and she said, geez, what changes your clinical management? And I think that's really the question I try to lead with. I'm a little different in that I care for a lot of high acuity patients. So patients that are, some that were sort of nearing the point of being transferred to methadone probably as this all started. So I feel some obligation to continue to monitor them just from a safety perspective. The other thing is I specialize in pregnant women. So I have a number of situations with moms who are home with very small children, with people who've lost their jobs. We know that people are stressed. I mean, I did probably 20 telephone visits yesterday. And I mean, I think the first 6 started with, I've been laid off, you know, I'm trying to collect unemployment, I'm really stressed out. And we know that sort of kids are at risk in these situations. And so I'm trying to really just sort of balance everything, trying to keep people safe in terms of not putting them in the community, but also trying to understand what's going on to make sure that I'm keeping kids safe at home that might otherwise be at risk. So we're certainly bringing people in with some regularity. We also have a random drug screen line where our patients actually call a phone number twice a week to hear whether they have to come in. Everybody in our program is assigned to a state in the US. So if you hear Texas or Arkansas or whatever, you have to come in. And we've actually adapted the message there to call the office if patients have concerns about coming in or if they're sick, because we want to really just verify whether patients are kind of engaging in treatment as opposed to necessarily bringing them in. So that's sort of an adaptation that we've made. But, you know, we're not bringing people in that are sick generally. We've had some situations where people are saying they're sick for now 4 weeks, and then it's like, how long do we keep them out of the clinic? I'm also work in a primary care practice, so it's a little bit different in that we have sick people coming into our primary care practice anyway. And we do saliva screens and are currently working with compliance around some type of system that would allow people to drive to our clinic and we could observe them doing their saliva screen through a window. So, you know, I feel like you just have to sort of throw everything in the air and go, what works, and try to find something that works, but that also meets compliance and rules and regs at the hospital. But so it's a challenge, but I don't think it's a challenge that I mean, everybody's feeling the same thing. And but I do try to lead with the question of, you know, does it change my management? Or, you know, and I do one other thing, sorry, I'm a little long-winded here, but you know, DHHS is basically the permanency caseworkers are working from home and not having the contact with these patients that they usually would. So there's a lot of structural systems that are typically in place that are not monitoring these patients as well as they would typically be. I have a good friend who's a probation officer. He's no longer going out and checking on patients or clients. So I think, you know, we're sort of the last means of keeping people on track in some cases. And I'm also trying to support patients. I have a couple patients who insist upon continuing to come in the office because they feel that's what keeps them on track. And I'm certainly not going to tell them they can't come. So I just try to do the best I can in each individual case, but I don't think I have any better answers than anyone else has out there.
Thank you for sharing. What are others doing, or do people have kind of questions around this? I mean, now's time, we're all together. We have a lot of people attempting different workflows, different ways to still kind of, you know, meet the needs. Are there other questions, thoughts that people would like to share?
This is Julian Kuffler from one of the things been trying at Down East Treatment Center is increased use of recovery coaches because they have the ability to connect. As others have pointed out, everyone else is pulling back. And in some ways, now's the time to push forward, at least with phone conversations, and recovery coaches tend to make better connections than the rest of us. So I would just think about offering that to patients.
Similar to that, there's a lot of online meetings now that are Smart Recovery Online and other things. I can send a link that I have from the Alliance for Addiction Recovery. And that's been very helpful. They've actually seen more patients coming to that virtual setting than they typically did in the past.
Please send in that link.
I sure can. Yep, I absolutely can. I have it in my email.
Great, thank you for sending that. Abby, not to put you on the spot, but can you kind of chime in from your viewpoints?
Yeah, absolutely. You did say Abby, right?
Yes, sorry.
Okay, great, thanks. So, a few things that really stand out to us and have been touched on a little bit here already is just concern for the increased risk that this vulnerable population is already experiencing, and around just the physical isolation. And we know that there's been an increase in access to online support meetings, and those are being shared and really generated. And I know a lot of our recovery resources have been sharing that information, but we see also a lot of barriers with some of the equity issues, particularly in Washington County and other rural parts of the state. Broadband is not available in all areas. Not all of our participants have smartphones, or they're managing children in the household that also need to be using technology at the same time. So we're trying to really support and find unique ways to reach those individuals, whether it's connecting via telephone, if that's an option for them. Also, of course, as Julian had shared, really partnering with and Healthy Acadians work with the recovery coaches. A few things that have also just been kind of top of mind is the impact that this will have on individuals that are engaged in current substance use. There's a school of thought that this might be an increased opportunity for them to access treatment services in recovery if they find that engagement in substance use just has significant barriers right now. And so we want to ensure that services that are providing MAT, and if they are taking new patients on, that information is available to those that share information, whether it's 211 or within the community. I was recently on a call with the Alliance of Addiction and Mental Health and listened to many providers from across the state. And that was one of their concerns, was that there was an assumption that their programs weren't taking people in, or that they couldn't access new services. So we're really trying to share that broadly, that MAT providers, although they're moving to virtual platforms, they're still offering these services, and also really ensuring that harm reduction services are made widely available. I recently talked to a community member that's a volunteer for main access points providing naloxone, and she had indicated an increased ask for naloxone by both family members and individuals that were currently engaged in substance use. So as MAT providers, I know many of you in your practice regularly make that offer to clients or provide naloxone to clients, but just ensuring that is part of our protocol as well. As Eric had said, there's a real increase in fentanyl. We're seeing an increase in fentanyl usage, particularly as other heroin and other illicit substances are maybe harder to access at this time. And so those are a couple of pieces that I'm hearing both from the community, and we're really trying to highlight and push forward, is that services are still available. They're being accessed in different ways, trying to break down barriers for community members that want to access these services, and also ensuring harm reduction strategies are in place.
Great, thank you for sharing that.
Can I add one thing to that?
Yeah, definitely.
So the only other piece that along the lines of harm reduction, our needle exchange has expanded hours, and we're able to offer more, so our being Main General. So if for anybody who's nearby or able to get here, it's expanded in both Augusta and Waterville, and we're offering things like food bags and other services through the needle exchange. So that can be a point of contact for people to get connected with some other services as well. We're seeing, anecdotally, that the price of drugs is going up on the streets, and there's sort of a lot of desperation right now, in addition to all the social factors that have already been mentioned.
Mm-hmm.
I'd just like to add in, as a primary care person in a private practice setting, I've actually gotten more calls recently from people that typically might have been calling groups or another organization and haven't heard back for whatever reason. So I think that there is an increase of individuals looking for treatment that might not have. Um, I'm able to get them in relatively quickly, although I'm not in my private practice because I'm doing some per diem work in the ER, but I am here every other day, so pretty quickly we can get them in. So that's been an interesting phenomenon for me to see that more people are turning to smaller practice as opposed to one of the bigger organizations um, at this stage. Many of my patients are patients I've had for years, having done this as long and been in a couple different settings. And so I've backed way off on urine drug screening counts, stuff like that. I've probably increased more phone calls to them and probably have more contact with them than I typically would, given that I think they need more support. But in terms of people looking for intake availability or getting started in the program, there's been several, which has been heartening in some ways.
I might just have a quick reflection that I think it's really interesting as the whole field of MAT has really moved to more supportive kind of treatment programming, that it has been really fascinating to see during this COVID-19 electronic medium era that we've actually pushed the envelope even further towards more risk or harm reduction approaches, meaning that we are spending a fair amount of time really supporting individuals, not necessarily doing the level of drug testing we were before, not necessarily stopping individuals who may have some other concerning use behavior. So it's actually fascinating. I wonder what it's going to be like when we resume back. I think that we will change. I mean, all of us are talking about how that our practice will probably change, but that we have been focusing a great deal on, some of the information from SEMSA as well as SEMSA coming out around, do we provide treatment? Do we provide MAT service without a counseling component? And at this point, we've really pushed the envelope, and we're utilizing, in many ways, an advanced sort of harm reduction approach during this era. And I think that we're going to have a lot of learning from this. And it's very possible that we are going to come back and say, maybe some of the highly more rigid structured approaches that we had been using demonstrates that we can practice differently. And we have done quite a few changes, as a matter of fact, in regard to that. So I think it'll be really, really very, very interesting. In terms of drug testing, some very creative things I think are occurring, which is very interesting. I think that the more that we can use testing as a treatment aid support and less of an enforcement arm, and that's what's causing this to happen at this point, it's actually allowing us to have a philosophical shift as we're in this era. And I think if we can sort of stop and collect some of our own data as we're going through this and do a comparison with practices before and seeing what learnings we have from it. And I do think we're going to learn a variety of things from this. So yeah, just a general reflection.
That was a great reflection. I completely 100% agree. It'll be interesting to see what the permanent changes are after all of this. I mean, I know there will be some things that go back in place. Just emergency rules will change. Certain methods will go back, but it'll be interesting to see the long-term effects of all of this. And it really pushed us as a state to finally launch into telehealth, which we've been a little bit behind in for years. So it was a push that was much needed. It's just unfortunate that all the infrastructure wasn't in place and ready to go for that. What other thoughts and questions do people have? Have you run into any scenarios where you're looking for some help with, you weren't really sure how to handle it? Anything that kind of came up? You can also type into chat as well.
I have a question
Mm-hmm.
for everybody. I had one individual who was released from jail early. Perfect. I think that was very reasonable. But came out saying, you know, he didn't have any medicine. He was told to deal with it later. And I was happy to, I mean, I knew him well. I think he needs a higher level of care than I can provide, but I'm happy to get him through this time. Again, risk reduction, I think he's doing pretty well. From what I can tell, I do check in with him weekly. He's not somebody I've given a long leash, but again, it's all by either FaceTime or telephone. Is anybody else seeing that, especially the jail population? Is anybody where are most of these folks going that are being released early?
Is this Kennebec County Jail?
Yes.
Yeah, so I can speak to that a little bit, unless anybody else wants to. So we're working on that. I didn't understand, and maybe this is helpful for other people who equally, it's kind of a black box for me, but I take care of a lot of people, obviously, who are in the jail. So as I understand, ENTO, which has the contract to provide the MAT at the jail, actually only has the contract where they provide the initiation for people who are not in treatment when they enter jail, which I thought they followed everyone. I didn't understand that. And then they arrange for follow-up when those clients are discharged. If the patient is on MAT when they get arrested or sentenced and they meet whatever the criteria is in the jail, which does change a little bit over time, then the jail medical staff actually continues them on buprenorphine, not to ENTO. And I think the challenge I've looped Gordon and Lisa and a couple other folks into this, some folks from SAMS, and I think what's not happening is that contact from the jail medical staff to external prescribers, in which case sometimes was us, but we don't have any knowledge that they're getting released at all, early or otherwise. And then there's a few people that have been released back to a prescriber that's no longer there, as I understand. So that's been a separate challenge. But the patients it's not being well communicated to the clients. And so they're going to the pharmacy when they get released from jail expecting to pick up a script, and that's not happening. So no, there's a large group of us behind the scenes trying to make this better. So we've had a couple people in super high risk situations that just sort of landed with us, and we're trying to keep them out of the ED, obviously, for the ED inductions. We're trying to not do that, but they've kind of floundered. And we actually had one person stay in jail over the weekend because she knew she was super high risk. And she chose to get out on Monday and then reported to our office about an hour later because she knew she was super high risk, which in some of these sort of beautiful moments, right, that these people identify what they need. And knew she probably wasn't going to be able to find Suboxone outside, so stayed in jail over the weekend. So anyway, which is not what we want them to do, but we're working on it. And I didn't understand the nuance of the ENTO versus the jail medical staff, so I may not be the only one that didn't understand that. But it does need to get better, and I'm trying to work with the right people to make sure that collaboration happens in a more robust way. To be continued.
Yeah, that's great. That's actually very helpful. And I trusted that. I felt like I had to trust that he was telling me the truth. And I really believed that, again, risk reduction was the better option. And so I've been giving him a week at a time, and I'm very comfortable with that, depending on where we end up down the road in terms of, and he's doing really well right now. So I think part of it is that it's not as accessible on the street right now.
Well, and I think I think part of this was exacerbated by the fact that a bunch of people got released early. So I think there was a bit of that. But I think it also just needs to improve overall. And I'm the scary part for me is that, people who don't know you exist or I exist or any of these other things, they just get let out into this wherever. And particularly if their prescriber is no longer there, which again is apparently in practice in Augusta. That's a super scary situation for a patient to find themselves in. And I do think there is a perception, as to your point, Jen, that, these practices are open to new patients, but patients don't perceive that. And I think it's because no one's there or no one's at the door or, things are dark. And so I think we need to continue to figure out a way You know, we've been trying to have staff at our office every day, and we have to make all the phone calls from the office, and that's the rules, at least at my place. So, you know, there's a perception that we're open. And I think we need to figure out how to have that perception be the same for some of these places that are completely online, that looked closed if you were to just drive by. So.
Just to kind of add to that, Elaine, a little bit, I know that there's no one perfect way to get all of the messaging out. And really, there's been a lot of discussion around trying to ensure that a lot of the information is kind of mobilized and reported to one place to be able to distribute it, because we see a lot of organizations respond in a way to want to make up like resource lists and get all this information out. And I know we position, and so we've really pulled our partners to say, how can we do this together so we're not all duplicating work? And I recognize, again, that there's no perfection in all of it, but I do know that 211 is really encouraging organizations to check in with them if they're not on their list. Make sure that you get on their list, because they're trying to really be that central hub. And we recognize that the governor's office and the CDC is pushing and you know, all of our community members to reach out to 211. So that might be one of those areas that we can just, as organizations, reach out to make sure that we're listed there, and if we're not, to get on that list.
Yeah, I want to add, thank you, Abby. Abby and I have been in some of those conversations together, and we're still in those conversations about what's the message and what's the best way to get a message out. And we were talking internally, and so I'm curious about the folks on this call and what your answer might be to this question of what's the message. And Elsie Flemings, our executive director, and I were talking about this yesterday. I think the message might be just as simple as help is still available, call first. Everybody's open, just call first, so that it's not a big long message about each individual spoke or site, but that it's one sort of simple, help is available, help is still available. So I'm just curious what people think about what the message should be.
I think from my perspective, I really like that message a lot. And I wonder if there's a role for community pharmacists to help support that message. So I think about maybe people that go to the pharmacy and buy over-the-counter loperamide to sort of self-treat withdrawal symptoms. That might be an opportunity to sort of engage people and let them know help is still available, or if there's a way that community pharmacy can somehow be part of that conversation.
Yeah, I mean, I agree with that completely. I remember asking my pregnant women, like, if I were to, you know, how would we find you? Like, if we wanted to get you into treatment earlier in the course of your pregnancy, and they were really clear, like pharmacies, supermarkets, Hannaford, Walmart, big box stores, and you know, somehow in the bathroom or near the bathroom or in that area they were like, that's where we will find it. So it's kind of on Stephanie's point.
Other thoughts on the messaging? Penny, I think that's probably the easiest way to go, and it's really just getting the major theme out there that there are still services available and we can help. Just call your specific area first. But other thoughts from people?
I'll bring this to the clinical advisory. Sorry if I cut somebody off. I'll bring it to the clinical advisory committee. We're meeting again this Thursday because of the acuity of the situation going on. Gordon's opioid response clinical advisory committee, and I'll try to see if we can wrestle this idea into sort of a smaller messaging type thing, because I love the simplicity of it, and I think that's just what we need to do. But if there's some kind of way that we could communicate it through all the MAT providers, that would be great.
Well, and I would say from the Down East Treatment Center that most of the folks that come in there, they all know each other, and they know people that are still out in the community and that aren't getting treatment. And so I guess to reinforce the notion to the people that are coming there already that, you know, we're still taking people in, we're still doing intakes, so that they can share that with people that, you know, might be seeking treatment.
That's a great thought. I love that idea, the messaging, and as you had said, Lisa, around getting the message out to the community because they share that information. And I would say on the other side of that, if there's any challenges with them accessing, just like you were saying, Jennifer, they've maybe called and they haven't gotten a response, that message also gets carried into the community. And that's where some of the assumptions are made that services are shut down. So we just want to make sure whoever's taking those calls, who are the ones answering those emails on the front lines, that messaging is consistent, or the message in the community among the community members will be, well, I called and I haven't heard back. So I think we're all kind of working on that in our organizations.
You may have reviewed this since I had to join late, but I know that we at the DTC have experienced an increase, and I've heard groups has, and I'm not sure about some of the other providers. And we were at a meeting with Gordon just this past week and talked about a variety of the theories behind it, and I think some of it has popped into earlier where access to street drugs is becoming a little more limited or a little harder to get, and potentially some who are in withdrawals trying to get access to MAT services. I'm just trying to get a sense of what it's like in the area, and are we seeing an increased requests in the past few weeks, and are consumers identifying why they're coming in? We kind of checked that they were increasing, but they weren't saying why. I guess I'm not going to come in and say my supplier is not as available, but just want to get a pulse of, are we seeing an increase in requests? And are any of the brave clients able to talk about why they're coming in at this point?
I mean, I think, yes, we're seeing an increase in requests. I've been trying to get information. Sometimes I have the folks at the needle exchange ask it because it's easier for them to ask than me, because for obvious reasons. But prices are going up is what I also understand. So there's sort of a supply issue. I don't know about quantities. I don't get into that. But I think also the sort of social way in which people acquired substances is obviously significantly reduced. And so I think there's sort of lots of variables, and kind of not wanting to be in sort of this desperate place where you have to go out and go to multiple different places and to acquire maybe a day's worth as opposed to entering treatment. So I think there's a lot of variables at play, but I definitely get the perception that is harder to come by, and also harder to come by so both our patients have less income, right, because they've gotten laid off from their jobs, or they're collecting unemployment, which is a third of what it was, or what they're reporting to me, and then also the prices are going up. So there's just a complete desperation all around.
Right. And one of the other, thank you, that's very helpful. One of the other reflections are that for people who have access on and off, they usually will buy street Suboxone to manage withdrawals. Well, part of the theory is that avenue is getting more limited, so the street Suboxone is potentially not as easily accessible as well. So now you both have the actual drug as well as the street, and so potentially bringing people in. But glad to hear that there's an increase, and that's a good thing. Not that we want to see the challenges they're experiencing, the users are experiencing, but if we can be there to support them, this is probably a great opportunity to really provide highly supportive care, of which they might be willing to stay with it. Yeah. Well, thank you. Just curious if we were seeing it elsewhere, but thanks.
Other questions or thoughts for each other? We still have a few more minutes. A lot of you have mentioned kind of an increase in the calls coming in, maybe looking for treatment services, but have any of you noticed with current patients if it seems like you're not hearing from some of them more, or do you have any concerns about patients that are currently kind of in your panel that you haven't heard from, you've been trying to check in with?
I don't know if people have it. My patients have changing phone numbers or no minutes on their phones, but also they live in such rural areas that it's like my staff will try to get in touch with them, and then they'll finally call back 2 hours later and be like, okay, if she calls at this time, and I put the phone, on the top of the second window of my second bedroom. I mean, it's like the service is so bad that it's all the limiting factors. That's really stressful for people. It's less about the kids running around at home, because usually they bring the kids with them anyway, so they're just running around my office. But it's sort of the the remoteness, right? I mean, my cell phone doesn't work in my own house. Sometimes my pager doesn't even go off. So it's the remoteness, I think, kind of really multiplied in this situation as well.
I would agree with that. I think so. We're seeing, some people just don't have internet access, phone access. They have less money now because the ones that were working have been laid off, and they're desperately trying to apply for unemployment, and that's yay or nay. You've got kids home that wouldn't necessarily be home, although a lot of times that also means older kids are home to watch the younger kids. Transportation issues. You don't have KV cap. You don't have, again, transportation is always an issue. Now it's an even bigger issue. So it feels like to me it's just this perfect storm. But in general, I'd have to say that, again, a lot of my people are been with me for a long time, but even some of the newer ones and some of the more tenuous ones that I've had more concern about over the last few months seem to be hanging in there. It's almost like they know that the alternative of turning back to using some sort of opiate or street drug has a whole new level of danger to it, and is that much harder to get. So even though there's this perfect storm of more barriers, I think they seem to be hanging in there for the most part.
I have found that I have a couple of people that were sort of, on the fence with their treatment, kind of teetering there, and they kind of go, right now they're going in and out. They'll disappear for a few days, and part of it is that we're not requiring them to do urine drug screens. We're not requiring them to show up for group. They participate by phone, and they can sort of do that selectively. And also the transportation issue. And, I can think of one person in particular that I know he is not supposed to be driving, and he was driving anyway, but now there's kind of more of a eye on those that aren't supposed to be driving. And so kind of all of those factors. But we still try, we still call and leave messages, and we're still here.
Great, thank you. So we are nearing the end of our time. We probably have a little bit of few more minutes for any final thoughts from folks. Also, if you do come up with a question, obviously we're always available to try to help answer. So even if it's like a week down the road, something happens, a specific scenario that you need help with, certainly we're helping. Caroline and Penny would probably echo that.
Yeah, I'll just add, I just wanted to invite Caroline or Lisa or Linda or some combination to just briefly describe the system where coaches are calling folks on request without entering full coaching relationships with them. Caroline, do you want to do that?
So, right, Julian, you had mentioned that now is the time to increase use of recovery coaches. And absolutely, that's imperative. In addition to that, an initiative we've got going at the DTC is for those folks who are isolated, which is a lot of people, obviously, and could use a check-in call. It happens to be a recovery coach doing the check-in calls, but this is different than a formalized recovery coach relationship. It's somebody picking up the phone and saying, how are you doing today? What's going on? And that just gives that individual a sense that they're not alone. So I urge all of you guys, it doesn't have to be a recovery coach. If there's a staff member that can take 15 minutes of his or her time simply to make human connection, that is very, very powerful. And who knows, maybe it could prevent somebody from doing something we wouldn't want them to do. So.
And I would add to that because of the technology challenges that a lot of our folks are having, that if a recovery coach calls somebody and they don't answer, they might not hear the phone. They may be blowing you off, but they might not hear the phone. And so maybe give them a couple of chances. I know we have one elderly lady that she just doesn't hear the phone half the time. So, but she would really benefit from a conversation. She would love that.
Yeah, and even to get that voice message that says, hey, we're trying to reach you, just want to see how you are. That could mean a lot. So.
Yeah, and I'm not sure she even has voicemail on her phone. So I think we just have to try and try again.
Yeah.
Great. Well, as I said, there will be more questions that arise as we go through some of this, and just as time happens, situations will occur where you might need extra support. So certainly feel free to reach out if you do find that your practice or yourself needs some extra support during this. Caroline, I'm going to turn it over to you to kind of summarize. It's not typical notes, it's more of, the different things folks are doing that people can take away and see if it would also work in your clinical setting.
Sure. So some of the meat of this conversation was, like we were just saying, to reduce isolation. And that can be done with brief check-in calls. It can be done by enhancing the use of recovery coaches. And it can also be done by having online meetings where people can have a sense of connection via whatever platform that is, Zoom, RingCentral. Also, there was discussion about barriers. So it's important that we recognize what are the barriers folks are facing that might not enable them to continue treatment. For example, Abby was making mention that bandwidth might be a problem, especially if your children are using bandwidth for school. So maybe providers and staff can come up with ways to knock down those barriers for patients. Another key point was the impact this is having on folks who are actively using. This might be an increased opportunity for those folks to access treatment. And as a result, this is important. It's important that we have information available that's reliable. So for 211, we got to get on 211's list, make sure that our organization is listed so that people know we're around to help. The messaging, to Penny's point, messaging is extremely important. Again, letting people know we're around to help. And something that Clem brought up, which I think was extremely important, is how is this going to affect all of us in the future? The world is changing, and this is really a philosophical shift. So now might be the opportunity to collect data to figure out, well, this is working really well. Maybe we want to implement this in the future. So that's kind of the meat of it. I know we talked about urine drug screens, saliva screens, but I feel that those are the big points.
Great, thank you for summarizing that.
All right, I just have two administrative things, Kayla started. Yeah, so put your name in chat if you've joined and haven't done that. That's really helpful because we keep attendance and we like to know who's joining. Also, I'm going to put the link to this survey. If you need a CME, please just cut and paste this and put it in your browser, and then you can get your CME. Otherwise, you may not receive CME for this if you don't click on it, so I'll send it right now.
Great, thank you. So we are nearing the close of today's session. I want to thank everyone for kind of taking a pause with us and going in a different direction for today, just so we could talk through some of these issues and make sure that people had a chance to kind of bounce ideas off of each other. Next month we will resume as normal with the case presentation is the plan at this point, and hopefully it'll be a little bit calmer by next month's session, which is on May 13th. I want to thank Eric for doing our didactic today. That was helpful and a great segue into the current times as well, very timely, so thank you for doing that. But otherwise, I think folks are good to go. Caroline, did you have any other closing announcements?
No, everybody just stay safe.
Yep. And if faculty can stay on, that would be great.
Yes, faculty stay on. I hope everyone else has a great afternoon. Stay safe.
Stay safe, stay healthy.
Mm-hmm.
I think we have some students who are joining just to see, but I think we're.
Did we lose them? Okay. All right. So I know that was probably not a traditional echo session, but we did feel like, you know, given everything going on, it was time to step back and just let folks either have questions or not, or be quiet and listen. But I just want to thank you all for kind of stepping up and providing information on what you're doing. There's a lot of adaptations and workflows and just different protocols at this point. So it was great to hear from all of you and get your input.